case illustration that we have coming up is a recent case that we treated at my institution regarding a 37-year-old male, and I'd like to also involve the audience and invite you to answer some polling questions. These are we'll provide a consensus answer after each question is presented to see how you would manage this patient. It's really, since we're not really able to get a show of hands in this type of environment and this method of lecture, but I'll be very interested to hear the commentary of our panel. This is a 37-year-old male who was found down, obtunded, intoxicated, and this is not an unusual scenario for our population. And he was moving bilateral upper extremities spontaneously and localizing with his lower extremities. And he had no verbal output, no eye opening, so about a GCS of 7. Next slide, please. So here's his scan, and this scan is representing a fair amount of diffuse injury at the offset. He's got subarachnoid hemorrhage on the left-hand side, and on the right-hand side, a small temporal frontal contusion, perhaps left frontal contusion, perhaps developing bifrontal contusions. And generally, if you look at the scan on the left-hand side, very compressed cistern. So what would you do first? So why don't we take it to the panel. Please click on the answer to the right to get the audience response to this. But I am going to invite Mr. Hutchinson to give a comment first, and then Dr. Timmons, and what would be the first initial thing to do for this patient.
Okay, so patient has a GCS of 7 and scan as we see, which looks sort of combination of diffuse injury, traumatic subarachnoid hemorrhage. So I think we would be very clear to take this patient to the NCCU, ventilate, and place an ICP monitor in the first instance.
Likewise, and of your selections, of placing an ICP monitor would be the first choice, that we would be doing things simultaneously, possibly mildly hyperventilating, although not severely, and obviously giving Mannitol for presumed high intracranial pressure due to the lack of this visibility of the cistern.
What's interesting is that sometimes my residents will call me and with this particular scan and say, I'd like to take this patient to the operating room for a hemicraniectomy. And this is when the patient first comes in. Yeah. Can we comment on why that would not be advisable or even advisable? What would your feeling be on that?
I think, the pressure may well be controlled with fairly standard medical treatment, and this patient could fall into the category of somebody who has a craniectomy who doesn't actually need it.
Right.
So that would be my concern.
The other thing is that many times, if this is a person who's found down intoxicated, they haven't yet been, mechanically ventilated and resuscitated, and oftentimes just tending to the ABCs, the edema will improve within a matter of a few hours. Yeah. So they need to be treated medically first.
Thank you. Let's have the next slide, please. Oh, and here's the result.
Yeah.
So the majority of everybody agrees to place the ICP monitor first. A small percentage with hyperventilating is the first. And hyperventilation is a good first step, just if you want to really get someone's ICP down, but obviously fraught with problems in creating ischemic problems. Anyone else with a comment regarding that? Okay.
No, just as I said, I might do that mildly at first, but then back off very quickly once the other treatments have been instituted.
Okay, we'll move on with what we did do. We did put an external ventricular drain and a brain tissue oxygen monitor, and the ICP was initially under 20. If we can go back to that second slide, great. On hospital day 1, the ICP did in fact increase to 37, so we maximized the sedation with propofol and midazolam, and we instituted pressors that are required to maintain the CPP in the 50 to 70 range as per the guidelines. And patient was given intermittent bolus as a Mannitol. We do believe in continuous drips of hypertonic saline at 3% just to maintain a normal sodium, because it's very common for the patients to develop hyponatremia, and so we want to try to avoid that. And the ICP did decrease to 27 and then increased to the 40s. Before we move on to the next slide, does anyone have any other commentary about that recipe of management?
That's pretty much exactly what I would have done as well, Jamie. The same stepwise progression as treatment, and basically all of it done at once as much as possible.
Yeah, I agree, and I guess the only other issue is what you would do about the management of the patient's temperature and whether you would start to cool them at this stage.
Okay, yeah. We're proponents of trying to maintain normothermia at the outset to try to avoid the hyperthermia, rather.
Yes.
Correct.
That's a very good point. Very good point. All right, let's have the next slide. All right, so this is his following scan because his ICP is not entirely well controlled, obviously. So obviously we're seeing flourishing of the left temporal contusion and flourishing of right temporal contusion and some bifrontal contusions. Not as horribly with that. There is maybe some mild improvement in the cisternal effacement, and obviously you see an EVD catheter. So the question for the audience and for our panel is, what would you do next? And a lot of the options here are more of the second tier management stage. So starting with Mr. Hutchinson, what would you do?
So we would start with hypothermia and a degree of hyperventilation and run this very much on the ICP. And then if we're still dealing with the refractory ICP, then this is the sort of patient that could be randomized in rescue ICP if we could get consent for that. But we wouldn't proceed to surgery straight off from the stage that you presented.
Dr. Taylor?
At this point, I think you said the ICP was in the 40s?
Yeah, it did spike up to the 40s.
So much like Mr. Hutchinson, I would hyperventilate and probably try to get the PCO2 to the 30 to 35 range. And if that were ineffective at getting the ICP down, maximally medically managed on the other indices, as you've indicated, euvolemic, hyperosmolar, temperature, not hyperthermic, then this is somebody that I would take to surgery. I would do a left-sided hemicraniectomy, and it looks like there's probably some subdural hematoma up front. Evacuate that. If the temporal contusion came out to the surface and seemed to be a coalesced clot, I might remove some of that hematoma there. But if it were more of a sort of pulped brain or salt and pepper type thing, I would leave that alone and do a duroplasty and leave the very large bone flap out.
Well, yeah, I do encourage everybody to participate and try to check off these responses, because we are interested in hearing what the audience would do, in fact, next. But let's go to the next slide. Oh, okay, so here we have the results before we actually go to the next slide. So of the people who did answer, there was a pretty fairly even distribution among the management strategies. So you know, there was, I guess maybe 26% would actually take the patient to the OR for whatever procedure it was, and then 13% would start high-dose barbiturates, and then, of course, there was 6% in the hypothermia and hyperventilation group, and some would not do any of those and do perhaps something else. Let me go on with what actually was done, I have to confess that we're sort of proponents of jumping to the decompressive craniectomy a little earlier in that process, even before inducing hypothermia. And we're, just simply because our experience has been favorable in doing this earlier rather than later in order to facilitate the management, but certainly that's by no means a standard, or perhaps everyone would agree with that. But we did plan to take the patient to the operating room. It happened to have been a day where the operating room was extraordinarily busy and there wasn't any room and no anesthesiologists available, and we basically were going to have to wait. So what we decided to do was, in the meanwhile, cool the patient with an external cooling device to a target brain temperature of 35 degrees, so a mild degree of hypothermia and hyperventilating to 31. We did have brain tissue oxygen monitoring, which remained stable. And lo and behold, the ICP, in fact, did decrease to 12 to 17. So we did so perhaps the decompressive craniectomy might have been premature because of the fact that we did have some success with this management strategy. In fact, his ICPs were better than they've ever been. And the brain temperature actually reached a target to about 36.6. So before we move on, does anyone have any other comment about what's happened so far? Shelley?
No, I mean, I think that that's a perfectly reasonable approach, and it obviously proved to be because his ICP came down, so we'll see what happens.
Good management, I'd say.
Yep.
Okay, so let's go on to the next slide. All right, so by hospital day 2, several ICP spikes occurred above 25, which did respond to boluses of mannitol, and the patient had some relative hypotension as a result of the management requiring increased pressors to maintain the CBP. So not only was he on neosynephrine, or phenylephrine, he was also on norepinephrine and, in fact, also on vasopressin. So he was starting to get onto 3 pressor agents. So the question is, what would you do next? And I really encourage everybody to respond to these and see what we would love to know what your management would be next. But starting with Dr. Timmons, what would be your next step?
I think I would try to, I mean, if he was really just having spikes that responded to the mannitol, I might continue to just go ahead and try to manage him medically, even on multiple pressors, as long as his volume was adequate and cardiac output was okay, no problems with ARDS or pneumonia. If there were pulmonary issues or brain tissue oxygen problems that might herald pulmonary issues to come, then I would, again, consider surgery.
Mr. Hutchinson?
Again, I would try and recruit this patient to rescue ICP because I think you could argue this either way. You know, there's potential role for ongoing medical treatment to try and avoid a craniectomy, but equally a craniectomy may solve the ICP problem, get the patient off some of the other agents, and get the patient off a ventilator more quickly. So, you know, I'm in equipoise over this issue.
I would just, I would agree with that, except for I would comment that the patient, having been on 3 pressors and having a hypotension, probably, or possibly at least due to the diuresis with mannitol, barbiturate therapy might be a problem, causing further hypotension.
Yeah.
And
sure. I mean, I wouldn't necessarily. I probably wouldn't start barbiturates in this patient. Right. I would run them in a medical arm, but without the barbiturates, and tolerate the ICP spikes. I think the problem would be if the ICP became refractory at this point.
Sure.
Yeah.
Okay, so
the medical arm of rescue ICP, the barbiturates are not obligatory. So.
Well, yeah, I would agree. I think this barbiturates would end up posing a further threat for hypotension. And, of course, as Dr. Timmons had mentioned about cardiac output, sometimes I know a lot of critical care people are kind of reluctant to put in the PA catheters, but if you are going to advance the management in from the medical arm, I think that type of more invasive monitoring may be necessary. Would you agree with that?
Yeah, absolutely. I mean, once you go down the road of multiple pressor agents, and I think that, at the very least, central line is indicated with management with using the CVP, but at this point I think a PA catheter would be required.
Jamie, there's a nice question from Andrew Nemanek on the chat. What happened to brain tissue oxygen with ICP spikes?
They actually never changed. They were actually above the 20 threshold throughout this time, so that actually did not factor into the decision making. But well, I'll tell you what we did do next, obviously, but interestingly enough, we now have maybe about 44% wanting to take this patient to the operating room of those who did answered, and of course, maybe about 18% trying to, or 12% continuing on, and 6% who would not do any of these things. So let's go on to the next slide. I know we're going a little bit over time, but I would like to just put some closure on this situation. We actually did take the patient at that point to a craniectomy because it's just been our experience that when they start running this slippery slope that they're really eventually going to need it. Especially with the pressor management, if they're really having problems with the hypotension, we tend to take the patients earlier, and that tends to resolve the need to have a lot of pressors on board. This patient did respond very well to a decompressive craniectomy with a decrease in the ICP. The brain tissue oxygenation was 28. However, interestingly enough, that actually decreased to 19 with a hematocrit of 26 in the postoperative period, and it actually did respond to transfusion. And if it may be a good tool in our experience if you have brain tissue oxygenation and the critical care people are reluctant to give transfusions above the 21 threshold of the TRIC trial, that perhaps this gives more fuel to argue in favor of transfusion. I know that's not necessarily the focus of this talk, but does anyone, Mr. Hodgson, you have a comment on that as well?
No, I mean that's exactly what we would do, and we're big fans of monitoring brain tissue oxygen.
So. Same, and Andrew Nemechek's comment about the toleration of ICP spikes when the PbTO2 is good, I think, is a good point. If the oxygenation is all right, then you might well tolerate some spikes. But to Jamie's point about the therapeutic intensity level, I think that's a major point, because once the surgery is done, the aggressiveness of the ICU care can oftentimes be dropped way back. But obviously, surgical blood loss and traumatic blood loss needs to be taken into account. And I think that the PbTO2 is going to help drive our understanding of what appropriate transfusion thresholds for TBI patients, separate from critical care patients in general, is going to be.
Well, thank you, Giz, because it's indeed you could go many ways, either way with this patient in continuing the full arm or going to the decompressive craniectomy arm. But as you say, I'm more of a proponent of decreasing the therapeutic intensity a little sooner and not having to subject the patient. If we believe that perhaps a lot of these interventions may result in other complications such as pulmonary or ARDS, to me it seems like taking that aspect away earlier might help those problems. Just to close up, the patient was discharged to TBI rehab by day 22, and actually this is his last scan before discharge. David, if you could click on the next slide there. I don't know if we can get that last scan up. I guess not, but, oh, here we go. Okay, but actually it does show, interestingly enough, some of the complications that Dr. Simmons mentioned with the hygroma on the opposite side, and then there's the hygroma underneath the flap. But it is agreed, I think, that we wouldn't want to be manipulating these unless they actually got worse. Yep. Does anyone have any other thought about that?
I would leave them alone. They're commonly seen, and I think if you start trying to drain them, then you run into infection problems.
Okay. Good. I do think we actually have one more question. Why do you attribute the ICP decrease to hypothermia, which is completely unproven? Why could you not conclude the ICP decreased in the absence of any additional treatment? Mr. Hutchinson?
In this particular case,
yeah.
I mean, we've got a lot of experience with hypothermia, and we think it's very effective at lowering intracranial pressure. But the problem is the complications, and we see problems with pulmonary complications and coagulation issues that have to be dealt with very aggressively.
Dr. Timmons?
Oh yeah, I'm not sure that I wouldn't necessarily attribute ICP decreases to the hypothermia, although Mr. Hutchinson is exactly right. It does work. It could also be just the natural course of the patient's brain edema resolving, and without being the person that was actually at the bedside sort of minute to minute, hour to hour, I'm not sure I could make that assessment either way.
Yeah, sure.
Yeah, of course these things are all happening within that 72 to 96-hour window of peak edema. So I think we can potentially attribute some of this ICP decrease to the effects of hypothermia. But I agree, if it were to go on longer, perhaps it could necessarily be the natural history of this. I think we are, in fact, out of time and gone over time. I do appreciate all the participation of our attendees today, and we definitely appreciate the participation of our faculty. Dr. Timmons, thank you for joining us, and Mr. Hutchinson, thank you very much for staying up late and joining us.
No, it's a pleasure. And, thank you for asking me.
And we certainly hope that you join us on the next webinar in our trauma series and all the wonderful other webinars that the CNS University has to offer. This presentation was recorded. You will be receiving a link to the archive in a few days. And if you wish to claim CME, wait until the presentation ends and you will be forwarded to the post-webinar evaluation and CME survey. Please take a moment to complete this evaluation and claim the CME that you're entitled to. And if you're not forwarded directly to the evaluation and CME form, you'll receive a link to this form along with a link to the archive within the next 2 days. Again, thank you for joining us, and please visit CNS University of Neurosurgery for information on other webinars. Thank you very much.